So again, thank you all for being here. I'm Alexa Tinsley. I'm the Director of Programs here at Jett Foundation. I want to thank you all for joining us for our community webinar series. Today, we welcome the Roche team to hear about their SHIELD DMD study that targets bone health in individuals with DMD. Today, we welcome Dr. Maitea, who is Principal Clinical Scientist and Development Leader in the Neuromuscular Department at Roche. She's been investigating treatments for Duchenne for the last 10 years. And we also have Sandra Bloom here, who is the Global Patient Partnership Leader for Roche, who will be here to help answer questions at the end of the presentation. Before we get started, I do just want to mention a few things. This is being recorded. So if for any reason you have to hop off, or if there is anybody that you know that wanted to attend this webinar today and may not have been able to, this recording will be available online. You can find it on our website, it'll be on our YouTube, and it will also live on Facebook for you to watch later on and be able to share to all of the places if you so choose. And everybody will get the link who has registered and is on this presentation today. We will also have a Q&A at the end of this webinar. We do primarily look at questions through the Q&A box, which if you look at the bottom of your screen, there is a bar. It has a box, like a little chat box with a question mark in it. So if you could, throughout the presentation, if you have any questions, please feel free to put your questions in there and we will get to them. We do try to monitor the chat, but if for some reason it's missed, please go ahead and email us after the fact and we will make sure it gets to the Roche team to try and get those questions answered. And for Facebook, we also do try to get to all those questions as well. But again, if for any reason your question is not answered, please feel free to send them our way. There is also closed captioning today. So on the bottom of your screen as well, there's a little box with a CC in it. You should be able to click that and you should have translation services in any language that is available on Zoom. If you have any issues with that, please go ahead and message us and we will try to get that figured out for you. And with that, I will hand it off to Dr. Maitea. Thank you so much.
Thank you so much, Alexa. Let me start sharing my slides quickly so that people can look at nice pictures instead of just listening to myself. Can you see my screen?
Yeah,
the slides?
perfect.
Okay, great. Thank you, Alexa. So hi, everyone. As she said, my name is Maitea. I'm a scientist by training, and I work in developing drugs for Duchenne at the company called Roche. I'm very excited. We are very excited to be here today to share with you our story, to share with you what we have been doing for the last couple of years in trying to understand as much as possible about bone health in Duchenne. And this has helped us design our new clinical trial, which is called SHIELD DMD, to study the potential of a new drug, satralizumab, to target both bone health, both bone and muscles in Duchenne. First of all, a huge thank you to everyone for joining into this webinar, and also a thank you to the Jett Foundation for giving us this opportunity. Before I start, as always, we need to do a brief legal disclaimer where everybody needs to understand that we're sharing this presentation, this content, only with informational purpose, no promotional purposes, and that this does not constitute any type of medical advice. If you have any questions about your health, medical condition, please always consult your doctors and your treating physicians. Our presentation is going to have 3 parts. First, as Alexa mentioned, and as I said, we want to share with you our recent understanding of how bone health progresses in Duchenne and what bone health means for a person living with Duchenne. We think it's very important to share our understanding with the community so that we all, we're on the same page. And after, we want to show you the details and the information around our new clinical trial called SHIELD DMD. And at the end, as Alexa mentioned, we're going to have a session for a Q&A where you can ask us any questions that you might still have remaining. What do we know about bone health in Duchenne? The first very important fact to understand is that there is a direct and strong communication, a relationship between muscles and bones. And this is very important for their normal function. And this is true. This is what we call, by the way, the muscle bone unit. So they work together. And this is true in everyone, in every person. You can imagine a professional athlete, for example. They are very active. They build very strong muscles, and in turn, we know they're going to have strong bones as well. On the other hand, if you think about your grandparents, we know that with age we lose muscle mass, we become less active, and they will develop what we call fragile bones, and this is why our grandparents will break their bones more easily. What happens in Duchenne specifically is that because of the ongoing muscle atrophy, the weakness in our muscles, this is going to also have an impact on the bone. So people with Duchenne are going to develop also weaker bones, and they develop something called osteoporosis. In addition, the use of steroids will also make this even worse. So steroids are used, they're the standard of care to treat people with Duchenne, but we know they have many negative side effects, one of them being that they cause this weakening of the bones. So in people living with Duchenne, because of the ongoing muscle weakness, and on top of that, adding steroids, we're going to progressively develop weaker and weaker bones. There's many different consequences and complications from this bone fragility that we see in people living with Duchenne, including the fact that the bones can break easier and with what we call low trauma fragility fractures, which means that a smaller bump or a smaller fall can cause a bone fracture with a very small strength. We also know that one of the most common fractures in boys with Duchenne happen on the legs. And this, because we need to recover from this fracture, we might put a cast, we might need to be bed bound, rest on a wheelchair. This can also accelerate the loss of the strength in your legs and accelerate the loss of muscle mass, which can cause an early loss of mobility and cause this loss of ambulation earlier than what you would have supposed to. We also know that there's frequent fractures in the spine. So in Duchenne, because of the weakness of the back muscles and also spine deformities, there's a lot of pressure on the back, on the spine, on the vertebra. So happens what we call these vertebral compression fractures. And from all of this pressure, the vertebrae can break. And what we know is that once the first vertebra breaks, additional vertebrae will also break in what is called this fracture cascade. And this can cause a lot of complications, back pain, which is also quite burdensome. This is our very basic general understanding of how muscles and bones work together, how we need strong muscles to build strong bones, and what happens in Duchenne, how this progressively deteriorates by developing osteoporosis. What we wanted to do next was go a little farther, and we actually collected a lot of data, right? We're scientists, we're researchers, we guide our work through the data. And we collected a lot of data from what is published papers, research from other investigators from everywhere we could find. And we've collected data from almost 2,000 boys living with Duchenne. And also collaborated with different experts in the field, neuromuscular experts, endocrinologists, physicians, doctors, also collaborated with the community, the patient advocacy groups. We've been very busy for the last 2 years to make sure that we had the best understand the better that we could what bone health means in Duchenne and generate this common understanding within all of the experts of how bone health progresses and deteriorates in Duchenne. Also, we looked into our own clinical trial. It's mentioned here. We did a clinical trial in Duchenne a few years back, which was called Spitfire, where we recruited boys with Duchenne age 6 to 11. We followed them up for a year. The study was terminated in 2019. And what we did in this study is measure bone mineral density through a DEXA scan every 6 months. You might already be familiar with what a DEXA scan is. It's like a special X-ray, which allows us to see the density, the strength of your bones. So we were able to measure all of this bone mineral density in this trial from these participants, and also collect all of this data around bone health from different clinical trials and published data around there. And what we have seen is there's a very progressive and sure decline on bone mineral density in people living with Duchenne. So we see that as you age, the older you get, the bones will become weaker, and we see less of this bone mineral density. It doesn't mean bones will still grow. There's different kids, different ages, your bones will still grow, but the problem is that they grow slower or less than they're supposed to. So this is what we measure with bone mineral density, where we see there's a progressive decline with age. What was interesting in the Spitfire study is that we actually saw that most of the participants had a progressive and significant reduction in their bone mineral density or the bone strength already by 6 months. And this was made even worse by a year. So almost 79% of these participants had an actual decline in their bone mineral density within this year. What happens when you progressively lose bone mineral density and the bone strength is that this increases your risk for fracture. So we also saw in all of this data that the older the boy gets, the older the person gets, the higher the frequency or the higher the number of fractures, right? The risk for fracture increases because the bones are weaker and we see more fractures happening. The other interesting thing is that, as we know, steroids will have an impact on your bones, will cause osteoporosis as well. We also saw a relationship where the person has, the longer the treatment with steroids, the higher also the number of fractures that we were measuring. And lastly, I think it's some hopefully useful information. What we saw is that the most commonly observed fractures in boys with Duchenne happen both in the vertebrae, so in your spine, and the femur, so legs and back. This is a lot to understand, and this is a lot to hear, that there's obvious, because of the disease progression, we now know that bones will get weaker and fractures become more and more common. So we understand that there's a real value in preserving bone health and trying to make your bones stronger to prevent all of these problems. Currently, and luckily for the community, so there are new therapies approved and being developed to treat Duchenne, and all of them are mainly focused in improving your muscle strength and motor function, which makes sense. Duchenne is a muscular dystrophy. We really need to change the disease by making our muscles stronger. All of these approved new therapies are really good for your muscles, but we know that they do not prevent fractures. So we still need therapies to continue improving your muscle strength, but also then to try and prevent fractures and make your bones stronger. Currently, there's no approved therapies to treat this bone fragility in Duchenne. And what we know now, because of this, the natural history of the disease, is that preventing osteoporosis and fractures in Duchenne could really improve the quality of life of a boy living with Duchenne. We could even potentially prolong the ability to walk, prevent spinal deformities, back pain, reduce all of these visits to hospitals, and reduce the pain and really potentially improve quality of life. So this is why we are more and more now saying, and we've heard this also from the experts, the doctors, and from the community, that there's an urgent need to develop new therapies to improve bone health and make bones stronger in people living with Duchenne. And this is where I take you to the second part, because this is where the idea came from and where we said, well, can we do something about it? Do we have any drugs that could help with bone health in Duchenne? And this is where we came up with the idea to propose and run this new clinical trial, which is called SHIELD DMD. SHIELD DMD is a global international clinical trial to study a medicine that is called satralizumab. And we are going to study the safety and efficacy of satralizumab in boys or people with Duchenne aged 8 to 18, as I said in the beginning, to study whether it can impact the bones and the muscles in Duchenne boys. We're running this trial in 4 different countries. So it's ongoing in Italy, Spain, Poland, and of course in the United States. We have currently 7 centers, almost all open. I think we're gonna open the last 2 centers this month. So we're gonna have 7 centers in the US actively looking for participants for SHIELD DMD. In case you're interested in understanding more about the clinical trials or even considering participating in a clinical trial, please always visit clinicaltrials.gov. This is where you're gonna find more details about SHIELD DMD and also contact details to find, you can find which one of these centers will be closest to you, and you can get in touch with the study investigator to understand more about the trial. Before you even consider potentially participating in a clinical trial or understanding more, you're probably wondering, okay, so what is this satralizumab? What is this new drug? What does satralizumab do? So satralizumab is what we call a monoclonal antibody. So this is a drug designed from human proteins. It specifically blocks what we call the IL-6 receptor. So let's talk about IL-6. IL-6 is interleukin 6. This is a protein that is produced by many different cells. And for example, it's produced by muscle. We know it's produced by muscle. And we know that in Duchenne, this protein is elevated and this signaling is altered. What we know from this protein IL-6 is that it promotes inflammation. And we know inflammation, it's a real problem in people with Duchenne because the muscles get damaged due to all of this ongoing inflammation. What we have seen, other investigators have also seen that IL-6 signaling is altered in Duchenne, and it can cause and it can contribute to the muscle damage, and it can also contribute to the bone damage through all of this inflammation, activating inflammation. Satralizumab, what it does is it can bind to another protein, which is called the IL-6 receptor, to block IL-6 from doing any of these actions. And what you're probably interested in understanding is that it's injected via a prefilled syringe. So it's a subcutaneous injection or an injection under the skin given every 4 weeks. And I guess, lastly, for you to understand why we even propose this drug, it's not just because we know a lot about IL-6, this protein, but we actually did another, we researched further blood from people living with Duchenne from our Spitfire clinical trials. And what we saw was very interesting is that the IL-6 receptor, this protein, is elevated. It was elevated in the Duchenne participants. And this elevation was related also, there was a relationship with this protein and the bone mineral density in these participants. What we saw is that the higher the levels of this protein, the lower the bone mineral density in the Duchenne participants. So what we're hoping for, we're investigating now, is that whether by blocking this protein, can we then increase bone mineral density in people living with Duchenne? So this is what we're proposing with satralizumab. This is why we are proposing to test satralizumab in Duchenne. But there's still also another key aspect of satralizumab, which is one of the advantages of why testing satralizumab is a good idea. Because, so let's make clear that satralizumab is an investigational drug for Duchenne. But satralizumab has already been approved for another disease, another neurological disease, which is called NMOSD. You don't need to know anything about NMOSD. I always say this, but luckily for us, we know a lot about NMOSD. We have been researching NMOSD for years, and we've done clinical trials in NMOSD, and satralizumab has been approved, has been proven safe and efficacious for NMOSD patients. It's been approved in 91 different countries. We have treated so far over, I think it's over 4,000 people with NMOSD, and we have collected data for over 9 years. So we know a lot about it. And what we know is that for example, one of the most common adverse reactions after receiving satralizumab is a reduction or decrease in white blood cells. So these are some special cells in your blood. It can also cause headaches, it can cause joint pain, and it can also cause injection reactions, right? Injection site reactions, which can be either local or systemic. Local will include swelling, rash, pain, or itching in the injection site, but also can cause systemic reactions such as diarrhea or a headache. It's very important to understand that because what we do with satralizumab by blocking IL-6, and this is involved in inflammation and in different also processes with our immune system, we cannot take satralizumab if we are going through an active infection, like a hepatitis B or tuberculosis, because receiving satralizumab could have an impact in the way your immune system can fight these infections. So we know a lot about the safety. We know so far that satralizumab has been well tolerated in the people that have received satralizumab. What we don't know is about the safety of satralizumab in Duchenne. We do expect a similar safety profile, but that's why we are currently proposing and running a clinical trial to understand both the safety and the efficacy of satralizumab. And we're going to do this through SHIELD DMD, which is a 2-year-long clinical trial. It's an open label clinical trial, so every participant that joins SHIELD DMD will receive satralizumab. This is given, as I said, as an injection under the skin every 4 weeks. And they will receive satralizumab during 2 years. Before the participant can even join, we're going to have a screening period of up to 12 weeks, 3 months approximately, to understand whether they're eligible and it's safe for them to receive satralizumab. Then they will start receiving the therapy. We usually have clinical visits around every 3 to 6 months, a little bit more frequent right in the beginning. And then we're going to be measuring, we're going to be doing this DEXA scan to measure bone mineral density every 6 months, an X-ray to also check potential fractures in your spine every year. And also we're going to be doing the North Star, the 10-meter walk run, and the time to rise every 6 months to see how your muscle function, the motor function progresses. At the end of the trial, after the 2 years, or if you withdraw early and you stop participating, we will have a 3-month safety follow-up also to make sure everything is fine, even after having received satralizumab. The main objective of this study of SHIELD DMD is to measure changes in bone mineral density at 1 year, right? We're going to measure bone mineral density at baseline, then every 6 months, and we want to see if within a year there's changes in the bone mineral density due to this treatment, mainly of the what I call the lumbar spine, right, of your back. But we're also going to be measuring as key secondary objectives the bone mineral density of the total body and also of the hip and the femoral head every 6 months and at 1 year. We're also very much interested in understanding how satralizumab can influence bone metabolism. So we're going to be measuring different proteins in your blood, different biomarkers at different time points, and of course, counting and measuring the number of fractures, both long bone and vertebral fractures. And then the muscle function test, so North Star, 10-meter walk run, and the time to rise will be measured as exploratory objectives. Lastly, this will be my last slide, is important to understand who could qualify to participate in the SHIELD DMD study. So we're looking for participants that are, they have a confirmed Duchenne diagnosis. They are at least 8 years of age and right under 18, so 8 to 17 years of age. And they must be taking daily oral steroids for at least 12 months. And I know we said, but steroids have all this impact on your bones, but this is the reason, because we know most of the people with Duchenne are going to be taking steroids for the muscle function. And because steroids can have an impact on your bones, we want to make sure everybody is on the same regimen, taking steroids so that we can reduce this noise caused by steroids and measure the potential efficacy of satralizumab on the bones on top of that. We're looking to recruit 2 different groups of participants. We're currently recruiting participants for the group 1. So in group 1, we are looking for boys who are both able to walk or not able to walk, so ambulatory and non-ambulatory, aged 8 to 17. If they are ambulatory, they should have a previous history of a broken bone. So we're looking to those participants that have a manifestation, symptoms of their osteoporosis, that at least in their past years, they might have had a fracture. And if you're not able to walk, we're going to be looking for both participants with and without broken bones from before or at the time. Then once we enroll the whole group 1, we're going to be looking for participants for group 2, which is going to be a narrower, a smaller group, well, bigger number, but a narrower population, where we're only going to be recruiting then participants who are able to walk, aged 8 to 11, and they will be required to score at least 16 points on the North Star. And they should have not yet have any symptomatic manifestations, so no broken bones before. And what is key to understand is, as always in clinical trials, we want to reduce the potential noise or mixing of different drugs and therapies to be able to understand what satralizumab really does. So in our trial, we have recently changed these criteria. So we are now allowing participants who have received gene therapy and exon skippers. This is going to be allowed because these are therapies that treat the lack of dystrophy. So they're going to be helping with the muscle. But as I said, they will not have an impact on bone. So we can still measure the impact of satralizumab on bone, even on top of these therapies. And we also understand that with all of these new therapies coming into the market and different boys with Duchenne getting different therapies, we really need, as a company, companies really need to start generating data of the different combinations of different drugs, right? To understand what works better for each of them and what doesn't work potentially. So we do allow gene therapy and exon skippers. However, we are currently requiring a washout from either vamorolone or givinostat, because we know vamorolone does have an impact and changes these bone biomarkers, and givinostat is also another anti-inflammatory. We do not allow these drugs during the first year of the trial. But again, because of the reason I said that we really need to understand how all of these drugs interact with each other, whether we can find a combination that works best for each of the boys, we will allow taking vamorolone and givinostat during the second year. So we're hoping to recruit patients now, get them treated with satralizumab, and once all of these drugs continue to come into the market, they will receive whatever is available to them on top of satralizumab. And I think this was it for me. I hope you understand a little bit better now what bone health means, what impact bone health can have in a boy with Duchenne, and the details of our new clinical trial, SHIELD DMD. Before I forget and I finish, we would really like to thank everyone, every participant for clinical trials, their families, because you're helping us advance research in Duchenne and our understanding in Duchenne. And I hope what I share with you today is the best example of how we can use data from other trials, samples from other trials, to continue building our understanding of the disease and even developing new drugs to continue potentially helping in the future. Of course, a big thanks to patient advocacy groups, caregivers who continue to work with us in designing all of these trials and giving our drugs the best chance there is. Thanks to the Jett Foundation once again. Thank you, Sandra, and the whole Roche team behind this trial and all this work who made this possible. And thank you very much for your attention. We're going to be very happy to take any questions you might have now.
Thank you so much. And I love the visuals. They're like this picture.
I know. They're very nice.
They're really great. We do have a plethora of questions. So my first question is, is this study at this time, and I think I know the answer, only available to those who were born male, or are females also capable?
Yes. Currently, it's male at birth only.
Okay. And then, thank you for answering that. In terms of like bone infusions, are they able to still take this drug with bone infusions? And if so, is there any data that shows how it helps in correlation with bone infusions?
Very good question. Thank you. I just realized we haven't spoken about that. So I guess you're talking about bisphosphonates.
Mm-hmm.
So we know this is why I said there's no approved therapy. So bisphosphonates have not been approved for Duchenne, but they are part of the standard of care. And we're not going against bisphosphonates at all. But we know that even with bisphosphonate treatment, so they do have a positive impact on bone mineral density. But we have seen in our research and all of this data, and this is published, that even with bisphosphonate treatments, we still see fractures happening. So what we say is that there's still a need for additional therapies. That's the first point. Because bisphosphonates do have an impact on bone mineral density, For us to understand whether satralizumab can also have an impact on bone mineral density, we cannot mix them both. So we do require a washout period of bisphosphonates. What we say is that it's still an investigational therapy, but because of the MOA, we're hoping that it could, at least during the trial, have a similar effect as bisphosphonates do. This is a hypothesis. We cannot prove this, but this is what we're hoping for. So we require a washout period of bisphosphonates, and then they will start receiving satralizumab during the trial. And as I said, because we know with bisphosphonates, it would difficult our research, and it would make it very difficult for us to understand, if we see changes in bone mineral density, is it due to bisphosphonates? Is it due to satralizumab? So this is the reason why we require a washout of 6 months of bisphosphonates before joining the SHIELD DMD.
Makes sense. Is weight a factor in these, because that, it does have an effect on bones, and so what does that look like in the results, and is that being measured?
So do you mean during the trial or from what we know from natural history? So if
What do you know from natural history?
From natural history, so in Duchenne, we have not seen, so there's always a correlation between body weight. So the higher the body weight, just literally by the load on your bones, it can help prevent bone loss, right? And if we lose weight, bones also tend to get a little weaker. I don't think we have seen, I cannot really comment on that. So I'm trying to remember, but we didn't see a direct correlation between weight and bone mineral density, but I'm going to actually look into that. Good question. Theoretically, it could, right? The higher the body weight, the bigger the load on your bones, it could help preserve bone mineral density. What we're doing in SHIELD is we actually do have a range of body weight, by the way. So we're going to recruit boys between 20 kilos and 100 kilos, both included. This is also because of the dosing of how the dosing of satralizumab works. We're going to be measuring both weight and height as well to see whether there's changes in weight and height within the natural history progression and also with the satralizumab treatment. But yeah, I feel bad that we don't have an answer regarding whether there's a strong link between body weight and bone strength in Duchenne. I don't have that one.
No, thank you for the answer that you gave. It was a good answer, so thank you.
Thanks.
I know you talked about a Gamry and the washout, but then being able to take it after a year. So the question is, are there any studies currently that show what the numbers are for kids who are on a Gamry, or not yet?
Regarding bone health, you mean? Or
Yes.
or you mean, so regarding bone...
I'm assuming with this drug, that's the question I'm assuming is being asked, but I can't say for sure.
When you say this drug, do you mean satralizumab or Agamree?
Satralizumab, I can't pronounce it, but yes, that one.
Okay, so obviously there's no data research yet. We're just starting with the trial. So we're going to be treating participants with satralizumab, and what we would allow and we want to collect is data after a year, potentially of the combination of these two drugs.
Perfect.
Yep, I guess that probably answers.
It does. Awesome. And then are there going to be any cohorts in the future possibly for those with Becker?
So I don't have a proper answer to that. Me personally, as a scientist, I would say we will consider researching this drug in Becker's, but we first need to understand even if it's efficacious in Duchenne, right? We normally, as drug developers, we focus first on Duchenne because, at least from my side, we know more and it's easier to design a clinical trial and endpoints to measure changes in Duchenne. We would consider, if we do see that this has a positive impact in Duchenne, we would consider additionally researching this in the future for Becker's, but not at the moment.
Perfect. Thank you. And then question, when using DEXA, do you look at biological age or bone age, and why?
Both. So we're going to be, I'm not sure you can do biological age or bone age by DEXA. We do it, so we're going to be measuring bone age through an x-ray of the left hand. With DEXA, we're going to be looking into bone mineral density, total lean body mass, and fat mass. These are the usual parameters that DEXA gives us. For the other, so bone age, fractures, we're going to be doing X-ray. And we definitely want to see, because we know in Duchenne, we didn't mention all of this, but we know in Duchenne, there's also a bone age delay, which can be seen on the structure of the bones. So we do have that question whether satralizumab would have any impact on the bone age delay. So we're going to be measuring that in SHIELD DMD as well.
Perfect. That is all of the questions that I can see, but I'll give it another minute. If anybody does have any other questions, please feel free to put them through. I have also looked in the chat and I don't see any more in there, and same from Facebook. But again, we know that sometimes it takes time to process questions. It's a lot of information, good information, but it's a lot of information to process. So if you do have any questions, please feel free to reach out to info@jettfoundation.org, and we will get them back to the Roche team to see if they may be able to assist in answering the questions. As Dr. Maitea stated, they're still working on getting into clinical trials, so there may be questions that aren't able to be answered at this time, but we will definitely get it to the team.
Yeah, we certainly don't have any data yet. We're just, screening and recruiting participants now, but we will, and this is our commitment for sure, we will share the results when we get them. And once we have sufficient participants and when we understand safety and efficacy of this drug in Duchenne, we will for sure share this with the community.
Perfect. And then, just knowing, the cohorts and the ages, I think is super important. So again, I appreciate both of you for being here and sharing more even so early on. I think it is so important for the community to know what is coming. There is a question that just came through. Do you know if there will be travel assistance?
Yeah. Yes, we do, of course. Yeah, so that's, the minimum we can do at least is if you're interested in participating, for sure, we're going to be covering air travel, train, car, hotels, anything is needed related to the study, meals as well. So we do have travel coverage, economical travel coverage.
And then I think you already answered this, but if you could just reiterate, how long is the washout period for vamorolone and givinostat?
3 months for both of them, 12 weeks.
Awesome.
Yeah. I have to say, obviously, we don't want to, prevent anyone from receiving any therapies that could work for them. We're just seeing there might be some families who are still going to wait for these drugs, who have to wait for these drugs. So what we're offering is this opportunity of receiving satralizumab, participating in this trial, and getting these drugs a little later, and then have that combination therapy, which could potentially, be even more efficacious on both sides.
Right. Having data with and without.
Correct.
Awesome. Well, thank you again. Again, we appreciate you guys so much. And again, if anybody has any other questions, please feel free to reach out. I did just see one come through and I will send it after the fact. So thank you again. I appreciate you both. If for everybody on here, we thank you for being here and taking your time. Please go ahead and check out our other webinars coming up throughout the year, and we will hope to see you all soon. Have a great day, guys.
Thank you very much.